Alexandra Jones. I'm the editor of The Ophthalmologist, and I have a pleasure of speaking with Dr. David Lunt, glaucoma specialist. First of all, could you tell me a little bit about yourself and your practice?
Yeah, certainly. So first of all, thanks for the opportunity. My name is David Lunt, and I'm a consultant ophthalmologist specializing in complex glaucoma and cataract surgery. I'm the nominal lead of a UK hospital trust called South Tees Hospitals, NHS Foundation Trust, which is a tertiary referral centre covering a large area in northeast England. And I've built lots of our pathways from the ground up, including a review pathway and a new patient asynchronous virtual service for diagnosing and monitoring glaucoma. My complex expertise includes traditional incisional glaucoma surgery, such as trabeculectomy and aqueous shunt surgery, as well as a variety of laser and minimally invasive glaucoma surgery techniques.
At the World Glaucoma Congress, you presented a paper on the accuracy of various tonometry devices. Could you tell me a little bit about this paper?
Sure, yeah. So we conducted a prospective study looking at patients attending a single clinician's clinic over a 2-week period. This included patients newly referred into the clinic, so some of whom had no ocular abnormality, and review patients with a variety of different glaucoma subtypes. So following visual acuity check, patients then had 4 different tonometry checks, which were carried out in a variety of different orders and using standard masking techniques. The tonometers included all available in this particular department at the time, which were TONOPEN, eye care, Ocular Response Analyzer, and the IOP-G and IOP-CC readings were collected, and Goldmann Applanation Tonometry. Hysteresis data were also gathered using the aura, and ultrasound pachymetry was carried out using the PACmate.
And could you tell me about the key findings of the study?
Yeah, so there's several ways that you can analyze data in a study such as this. So one of the things we looked at was the correlation coefficient. So the correlation coefficient is a statistical measurement of the strength of relationship between the relative movements of 2 variables. So a score of 1 is complete correlation, and a score of 0 is no correlation whatsoever. So our study found that the IOP-G aura readings had a correlation coefficient of 0.951 when compared against the GAT or Goldmann Applanation Tonometry readings. This was superior to all other modalities. Now, personally, perhaps a more clinically useful metric is the percentage of patients measuring within 2 millimeters of the Goldmann readings. So this was the metric that that NICE, or the UK government's National Institute for Health and Clinical Excellence, used when performing their meta-analysis when they were assessing the accuracy of eye care in their MedTech Innovation Report. Incidentally, in that report, they found that eye care was within 2 millimeters of mercury of GAT approximately 50% of the time. In our study, we found that for the aura results were again superior. So the IOP-G was 85%, the IOP-CC was 74%, the eye care was just 30% in this particular study, and the TONOPEN was 61%. So for the purpose of the study, we did extend it further. I didn't actually report this at the World Glaucoma Congress, but we extended it to 3 millimeters of mercury. And the values then increased in all categories, obviously, but increased to 98% for the IOP-G, 90% for the IOP-CC, 63% for the eye care, and 72% for the TONOPEN.
That's great to hear. And could you tell me how these findings are relevant to clinicians?
Yeah, so I was initially interested to trial the aura. As I knew in my practice, there's a significant volume of treated lower risk glaucoma or suspect patients who, due to time and capacity pressures common in lots of units, that particular patient cohort were ideally suited to a virtual clinic model whereby the pathway is just a lot more efficient for the patient and the clinician. And it means that my face-to-face clinician time can be focused mainly on the acute or complex cases. So the findings were really interesting because one of the concerns with creating a virtual pathway is obviously patient safety. Eye pressure accuracy is really the most important parameter in this instance. As clinicians, we're already used to a clinical setting whereby visual acuity perimetry or visual field, and imaging is carried out by other allied healthcare practitioners or technicians. But eye pressure has traditionally been performed by the clinician making the management decisions. So before I set up the virtual service in my unit, I needed to be sure there was little to no possibility of any IOP or intraocular pressure underestimation. This is particularly risky, as this could lead to an underestimation of the required IOP control and potentially permittance of a faster rate of disease progression. In the virtual model, as the gap between visits in this pathway can be anything up to a clinic visit once every 24 months, the consequences obviously could be potentially visually devastating. The study findings, I think, achieved this, but in all honesty, I was surprised to see such closely responding readings when compared to my GAT readings.
And how would you respond to concerns about tonometer accuracy?
So if you're alluding to tonometer accuracy in terms of comparison with traditional air puff tonometry, for example, the technology within the Ocular Response Analyzer is just completely different to historical air puff tonometers. It's a question I commonly get asked by non-glaucoma ophthalmologist colleagues, within my department or trainees. As clinicians, in order to practice evidence-based medicine, something we should all strive for and be continually striving for, we have to be open to change. Modern cataract surgery, offering selective laser trabeculoplasty, and early in the treatment pathway for glaucoma patients, and increasingly minimally invasive techniques for surgically managing the glaucoma patient are all clear current examples of this. There's a healthy body of evidence now behind Aura versus GAT, Aura compared with GAT and the overall accuracy, and an increasing evidence to actually suggest that if anything, it could be more accurate than Goldmann Applanation Tonometry. It's also, I think, important to realize what we're comparing the tonometry with, or what we're comparing it against. It's clear that it's superior modality to historic air puff tonometry, which is profoundly affected by different corneal properties of different patients. We're really comparing it against time taken for the clinician to perform Goldmann Applanation Tonometry. We're comparing it against the allied healthcare professional lining up the eye care or tonopen perfectly for the most accurate readings. So it's a really exciting bit of kit, and something that I use now universally in all of my virtual patients.
Outside of the study, what are your personal experiences with tonometry and your recommendations for your glaucoma specialist colleagues?
So, of course, we've got to be careful in basing any recommendations on relatively small-scale, non-randomized studies. However, the evidence is mounting for modern air puff tonometers, such as the Aura, to be superior to other commonly used methods, and possibly even Goldmann tonometry. There are also other advantages of this modality of tonometry. It's relatively user-independent, with a relatively flat and short learning curve. There are cost savings. No topical anesthesia is required for the patient. There are no continuing costs of consumables. Also, there's no contact with the patient. So there's improved patient tolerability of this. And there's also some evidence to suggest that toleration is improved even compared with some of the older air puff tonometers. And, at times, in current times when infection is key, there's also a theoretical reduced risk of infection with this. With the prevalence of glaucoma estimated to increase significantly over the coming years as it's a disease of age and aging populations, this method of accurate IOP measurement will be invaluable, really, to enable eye departments to see more and more patients safely and effectively, and in particular in a virtual glaucoma clinic setting.
Dr. Lunt, thank you so much for your time today. It was a pleasure talking to you.
Thank you very much.